Ladies and gentlemen, Felix, thanks for the invitation. The first talk of this session will be very short. Aortic valve stenosis, standards available. I thought just tell the standards, then you're ready, but there are no standards. The only standard we have is the definition. So we can agree that aortic valve stenosis is a diminished opening of the aortic valve, leading to increased left ventricular workload and or decreased systemic cardiac output. Even if I tell and say obstructed opening, that would be wrong, because sometimes the valve is only too small. So diminished opening is the minimal standard, and that's with the standards. If we talk about how we call the different part of the aortic valve, you already heard in the morning, there's no agreement. And the study of Sievers showed that of more than 500 surgeons asked how they call the parts of the aortic valve, of the aortic root, how they call the entire thing, not 50% of the surgeons agreed on one term. So if we talk with each other, we probably will have difficulty. There is no standard about nomenclature. Is there a standard about the abnormality of the valves? No, there is no standard, because there can be a lot of things wrong with the valve and not two patients are the same. So we have this true bicuspid, I will not say two leaflet, but bileaflet or something like that, or monoleaflet, that's rubbish. The bicuspid or monocuspid valve, and we have problems with the commissures, with the leaflet, and with the apposition zones, and they are look different in different patients. Sometimes the valve tissue is involved and is thickened, rigid, stiff, and this can be different for different of the leaflets. And not only the macroscopy is different, also the matrix is in histology different, and the cells are different. Sometimes the aortic root is hypoplastic. We call it an hypoplastic valve ring, but we learned in the morning there is no such thing like a ring. Sometimes it's an isolated lesion, sometimes the lesion is combined with a lot of different problems, and every combination of two things makes a different problem. So here is a picture about the type of opening. So you see there are 10 types only in this picture, and not two patients look alike. So nature doesn't give standards for the lesion. So do we have treatment standards? I thought that's easy. But that's not true. The textbooks gives you totally different treatment recommendations. So the surgeons are the most aggressive, at least Mr. Jonas. He said a peak-to-peak catheter gradient of 20 to 30 millimeters is enough to do an intervention. Others say the gradient should be at least 70 millimeters of mercury. So the newest German textbook by Nick Haas says peak-to-peak catheter-derived 50 to 60 watt, 50 or 60. And the mean or peak Doppler-derived gradient, peak 70, and mean 40. Or the patient has to be symptomatic, and how has to be the gradient in the symptomatic patient. So we don't have a standard for that, and also the AHA recommendations don't give us a true standard. They talk about 50 or 40, but not comparable to the other textbooks. So there is no standard for treatment. There is no standard how to treat. We have at least 6 surgical methods to treat an aortic valve stenosis, maybe more. I'm not a surgeon. And we have at least 2 percutaneous interventions. We have the balloon valvuloplasty, we will hear about that, and we have transcatheter valves, which are not suited for children and not suited for young adults, but which are underway. And maybe somebody will speak up and says, we do it in a hybrid approach. I don't know. So no treatment standard. We have no standard how to assess the results. What should we look at? Survival, early survival, late survival, residual gradient, regurgitation, time and type of re-intervention, left ventricle and its mass, function, perfusion, exercise testing, development, quality of life, which medicaments are necessary. So we don't have any idea how to assess results, and we not even are able to have standards in scientific writing, and I think that's something that's truly amazing. You don't have to read these conclusions by Brown, but I found it's very interesting how in this paper balloon valvuloplasty is abbreviated. They call it BAD. That's balloon valvuloplasty. So if you read that, bad is bad, and the surgical saves life. That's for the introduction. It was easy. We don't have standards, so now we can start to discuss.